Assalamu alaikum. Good evening. I'm Dr. Tunaggina Afrin Khan from United Hospital, and I'm going to present my case here. My patient was a 73-year-old gentleman, hypertensive diabetic, who presented with us with a diagnosis of non-STMI. Echo revealed apical zone hypokinesia with LV ejection fraction of 55%. Biochemical parameters were within normal limit, and coronary angiogram was done on 25th February in this year. This is his coronary angiogram showing codominant LCX with significant lesion in distal LCX and very big, the ostial part of the very big OM, and also significant lesion at the proximal LAD, and calcification is also seen from proximal to mid LAD. Here we can see the codominant LCX here. There is also a big diagonal with an early origin from the LAD, which was also moderately diseased at the proximal part and severely diseased at its mid part. RC was normal. So the issues were, we had an calcified LAD, big diagonal, which was moderate to severely diseased, codominant LCX to OM lesion. So should we go for CABG or PCI? So we did the synthesis score, which showed the equal result for CABG or PCI. But EURA score showed high mortality for CABG. So we discussed the issues with the patient's party, and they opted for PCI. And we also had to deal with some issue while doing PCI in LAD, because distally the LAD was diffusely diseased. So probably the patency for the graft will not be good here if the CVG was done. So if it was a calcified LAD, so we needed to do either rota or intravascular lithotripsy. The big diagonal negotiation only it was pinched if we do the PCI in the LAD. For LCX, we decided to do PCI to LCX to OM, and we also decided to do pre and post procedure IVAS. We took EBU 3.06 French guide catheter, and we took run through floppy wear. We faced some difficulty to negotiate our wear into OM. Then we took the crusade, and we took another run through floppy, one through wear, and we passed to distal LCX one wear, and another where we could negotiate into the distal OM. We first pre-dilated it with 1.5 into 15 balloon. And gradually it was pre-dilated with a 2 into 15 and 2 into 20 millimeter balloon. But we needed to do repeated pre-dilatation, because after the first pre-dilatation we faced difficulty to negotiate the stent, as it was a very tortuous vessel, and we vigorously pre-dilated it. Still we faced difficulty to negotiate our stent. Then we took a body wear, and after that we could negotiate the stent. It was a 2.5 into 24 millimeter drug-eluting stent, and we successfully stented the lesion. Then we took the same wear, and we wear the LAD, and we did the first IVAS. This is the most concentric part, the proximal part of the LAD, proximal to the D2. This is the proximal LAD, and then L6 is coming in view, and left main. So we also did another run-off of the IVAS to decide whether we should intervene the diagonal one. But after doing that, we could see the ostium of the diagonal one was having a good diameter. So we didn't went for 2-vessel PCI in this case in LED. So we decided to do IVL in this case. So it was a 3 into 12 millimeter intravascular lithotripsy balloon, and we did the IVL balloon pre-dilatation approximately with a 60 pulses. But we didn't do it at the same time. We took a few minutes interval before doing this balloon dilatation or intravascular lithotripsy. Then we negotiated the stent with 3 into 24 millimeter drug-eluting stent. Then we post-dilated. It was the post-stenting IVAS. And after doing the post-stenting IVAS, we could see some malapposition, and we post-dilated further. So my take-home message is intravascular lithotripsy is a safe and effective method for calcified lesion treatment, and intravascular imaging is mandatory to qualify the need and optimization of treatment with IVL, and to negotiate intracoronary balloon or stent in a tortuous vessel, body-wise support helps. So thank you all, and I recognize my teacher Dr. Afzalur Rahman sir in regard of this case, who had the confidence to let me proceed with this complicated case. Thank you all.